Thank you for the invitation to come and talk to you today. My name is Dan Hertz from the University of Michigan College of Pharmacy, and I'll be telling you about DPYD testing to ensure safe fluoropyrimidine treatment. There are two agents in the fluoropyrimidine class of chemotherapy. The first one is an oral drug called Capecitabine that is metabolized to 5-FU. The second drug is 5-FU itself that is administered intravenously. These drugs are used in many solid tumors, particularly colorectal cancer, and also breast, pancreatic, and several others that are listed here. As with most chemotherapy agents, treatment with these drugs is associated with severe toxicity, in this case including neutropenia and gastrointestinal toxicity. It's important to understand a little bit about the pharmacology of the fluoropyrimidines. These drugs are metabolized down one pathway for efficacy to the right. Their primary route of elimination, however, is this enzyme called dihydropyrimidine dehydrogenase, which we refer to as DPD. This enzyme is encoded by a gene called DPYD, and that'll be the focus of today's talk. Importantly, this DPD enzyme is responsible for about 80% of the elimination of the 5-FU in a patient's body. Over several decades, we have found several recurrent inherited genetic variants that reduce the activity of DPD. So I have listed here 5 DPYD genetic variants that are inherited by some patients. The top 2 lead to completely inactive DPD activity, whereas the bottom 3 lead to reduced DPD activity. The frequency of any individual variant is relatively low, but the combined frequency of carrying any variant is about 6% of patients. And you can see on the far right-hand side that the toxicity risk in a carrier of one of these variants is somewhere between a 50% increase and a 3-fold increase in toxicity risk. I have included here this P.Y186C variant that has been somewhat recently discovered. It is found almost exclusively in African-American patients, and although we know it's reduced activity, we're not quite sure exactly how much it increases toxicity risk. There are many other more rare variants in DPYD that have been reported. We suspect those to be reduced activity, but some of them we haven't confirmed this. In addition to the increase in severe toxicity risk, we know that patients who are carrying DPYD variants are at increased risk of death from fluoropyrimidine treatment. There have been multiple case reports of individual patients who died from fluoropyrimidine treatment and were later figured out to be DPYD variant carriers. Recent evidence suggests that if you give standard fluoropyrimidine dosing to a DPYD variant carrier, their risk of dying from treatment is somewhere around 3%. I have here an illustration of what exactly is occurring. If you have a patient with normal DPYD genotype, or what we call wild type genotype, and you give them the standard fluoropyrimidine dose, they experience the standard amount of drug in their body and the typical efficacy and toxicity, which is what we would want. However, if you have a patient who's a DPYD variant carrier and you give them the exact same fluoropyrimidine dose, they will have higher concentrations of the drug in their body, depicted here as the full coloration in their body, and that increases their toxicity risk, which we have depicted here in red. What we would like to do in my field of personalized treatment is to find these patients and reduce their doses so that you return them to having the expected and desired amount of fluoropyrimidine in their body, and they achieve what we'd expect in terms of typical efficacy and toxicity. You would not want to reduce doses in wild-type patients because this would lead to low drug concentrations in their body and decreased treatment effectiveness. We have done some prospective studies demonstrating the benefits of pretreatment DPYD testing and DPYD-informed dosing. If you take patients who are DPYD star 2A carriers that you find from testing and reduce their doses, and then compare them to star 2A carriers who were not tested and received standard dosing, you see a dramatic reduction in severe toxicity from about 70% to about 30%, and a reduction in fatal toxicity from about 10%, or what we now know to be more like 3%, to a 0% risk. We have also compared the outcomes in your star 2A carriers who receive reduced dosing versus your non-carriers, your wild-type patients receiving standard dosing. We have confirmed that in these two patients, you equalize their dosing, and they experience similar toxicity and similar drug concentrations. So we expect no reduction in efficacy from dose reduction. So we don't think about this as reduced dosing. We think about it as actually equalized dosing because these patients have lower metabolic elimination of the fluoropyrimidines. We have also shown that DPYD screening to inform treatment actually saves money. It saves somewhere between $50 and $60 per patient because of the avoidance of toxicity and hospitalization. Based on all of this evidence, we now have guidelines for how you should dose fluoropyrimidines in patients with known DPD activity. In the top row here are your normal metabolizer wild-type patients who have two normal DPYD genotypes in whom they should receive the standard dosage and administration of fluoropyrimidines. In our patients who carry a single genetic variant, who we refer to as intermediate metabolizers, their dose should be reduced by about 50% and should be adjusted as needed based on tolerability. In patients that carry two reduced or no functional alleles, these patients should have a dramatic reduction in dosing, somewhere around 90 to 99%, again, followed by titration of dosing based on how they're tolerating treatment. Because of the evidence that we've accumulated, including the study that I showed you, pre-treatment DPYD testing is recommended across Europe. The European Society of Medical Oncology gives pre-treatment testing a recommendation of strength A, meaning their highest level of recommendation based on a demonstrated clinical benefit. Pre-treatment DPD or DPYD testing is required in France and the Netherlands and is recommended across most of Europe, including by the European Medicines Agency. However, pre-treatment testing has not been recommended in the United States. It is not currently required or recommended by the FDA and has not been recommended by ASCO or the NCCN, which are the two main clinical oncology organizations. Testing is known to be uncommon in the United States, and we estimate that less than 5% of medical oncologists are actually testing their patients. In order to understand more about the prevalence and perceptions about testing, we surveyed US-based medical oncologists who practice in gastrointestinal and breast cancer. We received responses from 59 patients, of whom 20% say they have ever ordered pretreatment DPD testing, and only 3% say that they test selected patients. That would be 10 to 49% of their patients. The other 10 medical oncologists said that they have only ordered testing in less than 10% of their patients. We then asked about their perceptions about testing. We found out that there is consensus among medical oncologists that patients who are DPD deficient have increased toxicity risk. You can see here in this figure that almost all of our medical oncologists either strongly or somewhat agreed with this statement, with only one medical oncologist neither agreeing or disagreeing. We then asked a similar question about whether medical oncologists agree that DPYD testing is useful to guide treatment. Only 32%, or about a third, of our medical oncologists strongly or somewhat agreed with this statement, with many others either not agreeing or being unsure, or neither agreeing nor disagreeing. We then wanted to know what are the different factors that are preventing medical oncologists from ordering testing. All the factors that we asked about are listed here in descending order of how often they were selected. You can see that the number one reason was a perception of a low prevalence of DPD deficiency. You can see that 54% of the medical oncologists said that this was an extremely or very important factor that prevented them from testing. Another concern that came up was that there's an potential for increased cost to my patient or increased cost to the overall healthcare system, though this wasn't as important of a factor. The second most important factor was the lack of guideline recommendations, as I mentioned, from the ASCO or NCCN committees. Another factor that came up from many of the medical oncologists was uncertainty about how to order a test, what to do with the results, or which test to order. So there are some work that we need to do on the education side. Finally, there are some medical oncologists that continue to be concerned about a decreased efficacy if you reduce dosing, although as I mentioned earlier, we know that The reduction in dosing leads to a normalization or an equivalence of the fluoropyrimidine concentrations, so we do not expect there is any decrease in efficacy. Again, thank you very much for the invitation and for your attention. I will now hand it over to Ken Serprenant, the founder and director of the Advocates for Universal DPD DPYD Testing, who will tell you about his experience as a patient and a patient advocate in this space.
Thank you, Dr. Hertz, for that great introduction of the subject. And thank you, Martha Raymond, for including us on your agenda today so that we can share with you the risk that DPD deficiency presents and what we might be able to do to change the standard of care to improve outcomes for these patients. 10 years ago, I didn't know anything about DPD deficiency, and I'm sad to say that I did learn about it, but how I discovered the subject was my first wife, Kath, was detected to have rectal cancer, and we went and did our due diligence to see what sort of treatment she can expect. And we went to 3 different cancer centers, each of whom recommended surgery, radiation therapy, and chemotherapy. And she was assured that the chemotherapy was fairly well tolerated. She wouldn't even have to worry about losing her hair. So she chose to start with the chemotherapy. And there's the old expression, for want of a nail, the horse was lost, and ultimately the battle was lost. Well, in this case here, for want of sufficient DPD activity, we lost a patient. She had a single treatment of FOLFOX, which included 5-FU, and within a matter of days, she presented with symptoms that she reported to her oncologist, and the oncologist indicated that it was too early for her to worry about these. But thankfully, she persisted and got a medication to deal with the mucositis in her mouth. But her condition deteriorated. She got increasingly weaker, dehydrated, and suffered an extreme case of diarrhea at the end of the week. And then on the 9th day, she collapsed, and I had her hospitalized. It was there in the emergency room that I first heard anything about DPD deficiency. Well, her oncologist was confident that she was going to be able to come through this, walk out of the hospital within a short matter of time. Well, within 2 weeks of being hospitalized, the last 3 days of which she was in the ICU, she passed away. The image on the left is of her 3 weeks prior to the start of treatment. The image on the right is her in the emergency room. What that fails to convey to you is that the chemotherapy persisted within her body and was attacking healthy cells just as it was intended to attack the cancer cells. And so it was destroying her from the inside out. So after experiencing this, I had to ask, is this a unique case? And sadly, I've come to learn that it was not so unique. Yet, what I also discovered is that the organizations responsible for drug labels and treatment guidelines considered this to be a rare condition and therefore an acceptable risk. So looking at the numbers in the medical research, as Dr. Hertz reported, there is between 3 to 7% of the population has this variant. And if they are treated with standard dosing, that they are at risk of severe toxicity, which leads to hospitalization, perhaps even to ICU care and to death. Now, if you extend that out in terms of the number of patients that are treated in the US, on an annual basis, over 1,000 people are passing away. Now, let that sink in for a moment and ask yourself, well, what other industries would accept that as an acceptable risk without taking a look at its processes that might lead to this? And so we hope that by the advocacy efforts that we're going to talk about here, that we will indeed find more people that will join in on this and see and understand that the frequency that we observe today in the US doesn't need to be as high as it is, because in fact, pre-screening and dose management is cost-effective and leads to saving lives. So it wasn't good enough to just learn about this. I felt that I needed to share this. And so share this and become an advocate. And the old Chinese expression of a journey of 1,000 miles begins with the first step. Well, the first step for me was to be able to publish this, what I was able to discover on a website so that people might find out about this. Thankfully, people have connected after reading this information. The sad part is that they learn of this too late. They learn of this after someone that they love has suffered either a severe toxic reaction or has passed away. And you're going to learn a little bit more about that in a few moments. The other part of advocacy is that, well, not only sharing that information, but looking to see about changes in guidelines that can lead to an improved care. And so you'll hear more about that in terms of the guidelines in the following charts. Thankfully, what I've also discovered is that there are other people that are out there that have led the change in Europe and the province of Quebec, Canada, and that now there's an increasing number of medical professionals here in the US that are willing to consider the benefits of testing. Well, if we're on a journey, the first question that comes up often is that, are we there yet? So I'm going to give you a spoiler alert. No, we're not. But there are signs that show that we are on the right path. We're on the right road to seeing ultimately what I believe is going to lead to an improvement in care. Back in 2016, the FDA changed its drug labels, and they acknowledged that there was greater risk than they previously had indicated for DPD deficient patients. However, they did not adopt the recommendation for pre-screening. What we've seen is that Europe is in fact leading the way, where there are countries there that are requiring it and or recommending that patients undergo screening prior to the start of this treatment. And thankfully, we're seeing more people and we're having more opportunities, such as today, to be able to talk about this. An encouraging bit of information just released was President Biden's initiative again to reinvigorate the cancer moonshot. And one of the points on there, as you see here, is the right treatments for the right patients. It's a novel idea. Should not only look at the cancerous tumor that they have and come up with a recommendation for that, but we need to be able to assess, is the patient able to withstand the treatment that we are recommending? In 2021, there was one more death that we found to just be too much. And that served as a catalyst for us to come together, to form this advocate group here. And you can see our mission is to try to improve patient outcomes, and that is by requiring testing before the start of this treatment. We're doing it by trying to connect individuals, and I'm going to talk about a couple of other initiatives on this on the following slides. But one of the things that I want you to understand is that looking at these patients here, or these former patients, is there any indication there of an outward sign that would suggest to you that they are DPD deficient? I submit not. One thing they might say is that, well, this is an all-white issue. That's not true either. As Dr. Hertz pointed out to you, that there is a variant that we know that is a significant percentage of the African-American population has. What this shows you is that we only know really the tip of the iceberg in terms of the number of people that are actually affected by this. So another initiative that we have is we need to share. We need to share what it is that we are learning. And one of the things that we're trying to do is we're presenting at conferences such as this, what it is, the value of pre-screening, but we also want to be able to give credit to those people in the US who indeed are on the leading edge. They're out there talking about the advantage of testing, but not only are they talking about it, but they're implementing it. And we hope by sharing this, that even though the guidelines have not changed, what we will see is that we will see more practitioners who are willing to move out ahead and to be able to do what is right for the patient by screening before they administer the first dose. So while we are trying to promote that sort of behavior at the grassroots level, the other thing that we're trying to do is we still are trying to address treatment guidelines and drug labels. And so thankfully in 2021, we got support for pre-screening from ISMP and NCODA. We are still waiting for the FDA to rule on a submission from a citizen petition back in 2020. You can see here what it is that we asked for. Our hope is that the FDA will rule soon and that they will embrace the recommendations of the EMA. We don't have any success yet with the NCCN for treatment guidelines, but we learned something in 2021, and that is that they are concerned with the efficacy of cutting back on the dosage for patients, thinking that the chemo will be ineffective. Well, we know this is that there's a significant risk of severe toxicity for patients that have this variant if they receive standard dosing, and that there's an unacceptable level of risk of patients dying from this. So we're not done. We will continue to present evidence on the efficacy of this to the NCCN. So can you help? Sure. One, learn more about this. You can do this at a site that I'm going to share with you here in a moment. You could also learn about this at by reading the petition that we had before the FDA. And you can speak with people. And if you're a patient, you absolutely should be talking about this subject with your oncologist, and in fact, ask for pre-screening. Thank you for the opportunity to share this with you today.